دكتور نيرة.
Okay, start
Okay,
waiting.
we're back.
Okay.
Okay. Are you there? Everyone here?
I am
Yes,
here.
sir.
Yes, I'm here.
Yes, we are here.
Let's restart the question from the end of discrimination. Just
Okay.
TSH is normal if 54 is low. Prolactin is mildly elevated, LH is mildly elevated, but we must know that LH is mildly elevated in a patient with female patient 47, so it may be postmenopausal range, may be normal this for age. Cortisol is normal. The patient receives phenytoin, lofipramine, some another drug and proton pump. What is the most likely explanation of her abnormal thyroid function? T34 is low, TSH is normal. Is it say interference or Cushing or phenytoin or non-functional pituitary adenoma or non-thyroidal illness syndrome?
Non-thyroid illness.
No, non-thyroid illness excluded because 34 is the last one to be decreased.
Yes,
And
yes,
TSH
but
is
then
low.
in sick euthyroid syndrome, the patient is severely ill, critically ill. Patient in ICU,
Yes.
it is a critically ill patient. And we said about it, it is low T3 syndrome. T3 must be low, the next 34 or total T3 is low. TSH is mildly low. And
I think
maybe
this
normal.
one is the effect of phenytoin, Dr. Khalid. It's one which affects
Phenytoin.
34, I think.
Enzyme inducer.
Phenytoin, yes.
I am with phenytoin.
Yes, I'm with you, phenytoin. And I want to mention this image from a drug that affect thyroid function, phenytoin, carbimazole, phenobarbital, valproic acid, all of them decrease the total T4 and may affect the 54. TSH is normal. Phenytoin, carbimazole, phenobarbital, valproic acid, all affect the total T4 and may affect the 54 and may be lower than normal. TSH must be normal. Okay.
Okay.
Another question.
Prolactin also?
What?
Affected prolactin?
No. Not affected.
Prolactin is only mild increase. It can increase by anything.
Anything, especially drugs, antipsychotic drugs.
Anything can increase. It's little bit high. Guidelines, which of the following option have ultrasound features of a benign thyroid nodule? 1. Solid hypoechoic relative to the normal thyroid tissue nodule, which may contain macrocalcification, a taller than wide shape.
Is the criteria benign, Dr. Is the criteria number 1 benign or non-benign?
I think solid hypoechoic is not a benign.
Yes.
At least it's not U2.
الماكرو calcification fine. المايكرو
Yes, macro is away, but solid hypoechoic I cannot take it easily.
طبعا.
Yes.
Taller than wide also it's not.
Risk.
Irregular margin and taller than wide it's not.
Yes.
Irregular margin intranodular vascularity is not.
In any irregular margin is not a benign
Yes,
feature.
it's not. So I think the last one, eggshell calcification around periphery of nodule. Only it's not if there is extrusion of the surface. Here no extrusion to the one.
Yes, of course.
I think the answer is 5.
Okay. All are accept the answer 5?
Yes.
Yes.
My question
This is the benign
vascular.
What's the question?
Hypervascularity. Intranuclear
Yes, in the
hypervascularity.
periphery is not, but central. He said central.
Central hypervascularity is with benign or malignant feature.
Malignant.
I think
Malignant, of course. Central hypervascularity is malignant, but peripheral hypervascularity may be benign feature.
Yes, benign.
Okay. Yes, of course. Of course, spongiform or pluricystic nodule is a benign feature. Eggshell type calcification around the periphery of the nodule, benign feature. Iso-ochoic or mild hyper-ochoic in relation to surrounding is a benign feature. Peripheral vascularity on flow color of flow Doppler is a benign feature. Another one about amiodarone. In all examination amiodarone questions, at least one or two amiodarone questions in the exam.
Yes, but I remember it was very difficult in the exam.
Yes,
All
of
questions.
course. Some amiodarone is very, very difficult.
Yes.
Like
So
this is one of the difficult questions.
Yes, 69-year-old. Okay.
A 69-year-old man is reviewed at medical outpatient clinic complaining of tiredness, neck tenderness 6 months ago. He was admitted with angina associated with atrial fibrillation, which spontaneously settled following intravenous digoxin. Since then, he has been treated with amiodarone 200 milligram daily. He also takes aspirin and atenolol 50 milligram daily, together with bravastatin. Examination of the patient reveals fine tremor and a pulse of 56 beats per minute, blood pressure 146/88. Neck examination revealed no obvious goitre, but mild tenderness in the thyroid area. Investigation revealed free T4 33. It is high. Plasma TSH is low.
Is thyrotoxic.
Thyrotoxic. What the best management strategy for this patient? Continue amiodarone and start carbimazole. Stop amiodarone and start carbimazole. Stop amiodarone and start steroids.
Other options.
Okay.
The other option down. Continue amiodarone and start carbimazole. Stop amiodarone and start. Stop amiodarone only. Stop amiodarone and start carbimazole and flecainide.
To answer this question, in the first, what is the diagnosis? It is amiodarone-induced thyrotoxicosis or what?
Yes, amiodarone-induced thyrotoxicosis. But what?
To limit the answer, we must clarify that. Is it type 1 or type 2 amiodarone-induced thyrotoxicosis?
I think it's type 2.
Why type 2?
Because she has no goiter.
No goiter.
No goiter cannot exclude amiodarone.
Yes, you are right. I am searching. Medical outpatient clinic or tiredness and neck tenderness and concentration.
Just atrial flutter.
Yes. Occasional ventricular ectopics. So he still take amiodarone. So I cannot stop amiodarone.
The first duration of amiodarone 6 months. What is the most common amiodarone thyrotoxicosis, type 1 or type 2?
Type 2.
Type the most common. Of course, type 2. So there is no definite criteria to differentiate between type 1 and type 2 in this case. So I will select type 2. Type 2, which must be treated by steroid.
Okay. Steroid. Okay. So, but
in every case, if we can stop amiodarone, stop it.
But this patient still has occasional ventricular ectopics.
We can stop, I think, this one.
Is it ventricular ectopics critical to stop or
Not
not
critical.
to stop amiodarone?
I
But
don't think that
this ectopics with amiodarone. So what if I stop
So
it?
I am with you. So the only selection to continue amiodarone is to start with carbimazole. And
Yes.
all other options to stop amiodarone. So I must stop amiodarone here.
Yes. So number 3.
Stop.
But Dr. Khalid, in clinical practice, we cannot stop antiarrhythmic drugs. We have
Yes,
to
yes,
consult
of course.
the cardiologist to stop it.
Yes, yes, and the guidelines recommend this. Just not endocrinologist to stop amiodarone. Just we must discuss it with cardiologist. Of course, yes. But in exam, we must select one correct answer. So if we select continue amiodarone, we must select carbimazole, and in this case, it is type 1. I think it is type 2, so we must stop amiodarone here and start steroid or just stop amiodarone.
I should start.
But the treatment for type 2, it is steroids, not antithyroid drugs.
Yes,
Yes,
of course.
number
Yes,
3.
of course.
that's what we select.
Number 3.
Yes,
Select
oh,
number
okay.
Yes, of course. It is type 2 amiodarone-induced thyrotoxicosis. If we can stop amiodarone, so stop it. The half-life is very long. About the half-life of amiodarone, how much?
About 52.
96 days. 120 days.
56 days.
No. 50 or more than 50 days.
58 days or 56 days.
Sorry.
Another question.
58-year-old woman with a history of long-standing hypothyroidism due to Hashimoto's thyroiditis comes to the clinic for review. Over the past year, she had developed epilepsy and has been diagnosed with osteoporosis. Having sustained a left Cooley fracture, she complained of increased tiredness and weight gain over the past 6 months. Her TSH, previously stable in the middle of the normal range on 100 microgram of thyroxine per day, has risen to 6.5. It was stable and then risen to 6.5. Which of the following is the most likely cause? Denosumab, lamotrigine, levetiracetam, raloxifene, risidronate.
What is the
Which
drugs
one?
affect thyroxine? It's a very important topic. Which one affects thyroxine, absorption or clearance?
I think denosumab.
Why? I didn't
Another one?
remember about
No,
denosumab.
Rice brunette.
subcutaneous, so
I would go with number 5, rice brunette.
5 or 4, raloxifene.
I think raloxifene.
I am with you, of course.
Selective estrogen stimulator. And this is act like estrogen and raising the total.
Yes.
But
Yes,
if
of
raising the
course.
total, why TSH will rise?
It decreases the free.
Even if decrease the free.
Yes.
And so it is reflected to TSH to be high as a feedback mechanism.
Okay.
Interesting, yes.
Oral contraceptive pills, pregnancy, all of them affect the thyroxine, estrogen, raloxifene. Raloxifene will affect
But oral
thyroxine.
contraceptive pill, Dr. Khalid, affect the TSH?
Affect the total TBG, TBG male, TBG, and total T4.
لا.
What?
Okay. Okay, let's choose and read what he wrote. What's his comment?
think, okay. Raloxifene is recognized to reduce absorption of levothyroxine. It increases thyroxine binding. Decrease the absorption of levothyroxine. It increases thyroxine binding globulin, leading to reduction level of free thyroxine, and so increases TSH as a negative feedback. Other agents known to inhibit thyroxine: iron, calcium, aluminum hydroxide, cholestyramine, sacral feed. tamoxifen and estrogen are also recognized to increase the level of thyroxine binding globulin. Another drugs that affect the thyroxine, phenytoin, carbamazepine, they increase the clearance of thyroxine, and the dosage of thyroxine must be increased in this case. Phenytoin and carbamazepine. It is a very important topic that drugs that interfere with the thyroxine or affect the thyroid. Another one, the last one in this bank, and I will review some questions from a previous examination.
Okay. 55-year-old man was diagnosed with AF and commenced on amiodarone 2 years ago. His thyroid function tests prior to commencing amiodarone were normal. He subsequently developed hyperthyroidism whilst on amiodarone. Amiodarone stopped 4 months ago, but he continued to lose weight despite maintaining a good appetite. His present medication, digoxin and warfarin, as per INR, there is no family history of thyroid disease. On examination, pulse 92, irregular, blood pressure is 130/70. There was no goitre palpable on neck examination, and he had no visible tremors. So no goitre and no tremors. Investigation, sodium is 138, potassium 4.1, urea normal, creat normal, plasma 3T4 is high, about 3 times, plasma 3T3 is high, 1.5, plasma TSH is suppressed, serum peroxidase, antithyroid peroxidase negative, TSH receptor antibody is negative.
It is
What is the
amiodarone
next
used
most appropriate
type
in
1 or
this?
type 2? Type 1 or
It's
type
number
2?
one.
I
Number
am
one.
with type 2.
Type 2.
It is mostly type 2 because
Yes.
Antibodies are negative. It is type 2. Yes.
Yes. What's the
Yes.
next most appropriate investigation? Is it radioactive iodine uptake scan, or serum amiodarone level, or serum interleukin 6 level, or thyroid hormone receptor studies, or ultrasound scan of the thyroid?
How to
Radio-
differentiate between type and 2, type 2?
Radioactive iodine
In
uptake.
type 2, interleukin 6 is high in type 2.
But it is under research. It is
Yes,
not
it's not
fully
specific.
standardized.
I think
Radioactive
that is a
iodine
good
is
choice.
Ultrasound, low vascularity.
Radio.
Yeah.
I will go for radio.
Ultrasound. Ultrasound. If the question mentioned color flow Doppler ultrasonography, I select it. But the question answer ultrasound scan of the thyroid only. So it is not accurate to differentiate between type 1 and type 2.
The uptake scan is the correct answer, I think.
Yes, of course. The most accurate answer is radioactive iodine uptake. Color flow Doppler is the most appropriate answer if it is present. If not, radioactive iodine uptake scan. Radioactive iodine uptake seem to be about 0 in type 2 and maybe normal or high or low in type 1. In type 2, mostly be 0 uptake.
Yeah.
I will discuss some questions from previous exam, just a few questions, please. This is from the previous 217 exam, thyroid questions only. One of the questions I don't, the one who posts the recall don't post the 5 answers. So the mechanism of action of carbimazole, what is the mechanism of action of carbimazole?
Anti-thyroid studies.
TPO inhibitor, of course, but if the exam, this is from the latest guidelines published previous year, the mechanism of action of anti-thyroid drug, iodine oxidation inhibitor, organification, coupling, thyroglobulin biosynthesis, but we must notice that follicular cell growth inhibition. And of course, propylthiouracil prevent the conversion of T4 to T3 by deiodinase, D2
type 1.
course. Another question about enzyme responsible for hepatic conversion of T4 to T3. Which enzyme? The iodinase
Iodinase type 1
T1,
and the type 2.
1 or type 1 is present in
Present in
T1
the
is present in
liver and the muscles.
Liver,
Liver
kidney,
and
and
type 2
muscles.
present in yes,
Brain.
of
Hypothalamus and
course.
pituitary.
Brain or neuron type 2.
Type
Brain
3
or neuron. Type 3 في البلاسينتا.
yes, of course. Type 1 present in the liver, kidney, thyroid, and muscles. Type 2 present in the brain, pituitary neurons, especially neurons. Type 3 present mainly in the placenta. And type 1 conversion of T4 to T3, T4 to reverse T3. Type 2 conversion of T4 to T3 only. D3 conversion of T4 to reverse T3.
Yes.
Okay. Another question about daily requirement, iodine daily requirement. What is the daily dose requirement for iodine?
150 microgram. 150.
150 for adult male. What about the
Increase
pregnancy and the lactation?
Pregnant increase to 200.
250.
The dose it is 1.7 per kg in non-pregnant. In children, it is 2 microgram per kg, and in pregnancy, you have to increase by 25%. The maximum.
Dr. Khaldun, it is iodine intake. It is iodine intake.
Sorry, iodine. Sorry, I am sorry.
Iodine intake. This is the recommendation of WHO, daily requirement of iodine, RDA. Which dose? In adult male, 100.
159.
Pregnant female, how much?
200 microgram.
200.
Lactating?
250, I guess.
I think same like pregnant.
Pregnant, this table from Williams textbook of endocrinology latest edition, 13 edition, they mentioned that adult daily requirement 150 during the pregnancy and the lactation 200, children 90 to 120. But
Yes.
WHO recommendation during the pregnancy and lactation 250.
Okay. And in the choice, I don't think he put 200 and 250. I think if like that, it will be very difficult.
I don't know, but the WHO recommendation during pregnancy and lactation 250.
250. Yes.
Adults and adolescents 150, children 120, infants less than this number. This is a question. Percentage of shrinkage of goitre post radioactive iodine.
50%.
50%.
Yes.
20
yes.
to 30.
30, I guess.
After 1 year. This is from the guidelines of NICE guidelines published 277. Percentage of malignancy risk in Psi3F. In the first
Maybe
Psi3F,
15%.
in the first, what do we mean by Psi3F?
It's follicular.
Yes.
Suspicious of follicular. What is the management of Psi3F?
Victory.
What about Psi2A?
Atypical.
Non-diagnostic.
Non-diagnostic and rebiopsy.
And I mean, and the multidisciplinary team.
Must be rebiopsied. 3A. Risk of malignancy, percentage of malignancy risk in Psi3F about 20%. 20%. This is from Oxford Handbook. As we mentioned, this is very important. Psi1 non-diagnostic must be repeated. Psi2 non-neoplastic and repeat after 3 to 6 months to confirm benign. Psi3 abnormal cells. Psi3F follicular neoplasia cannot be excluded and treated by lobectomy. Psi4 suspicious but not diagnostic. Psi5 it is malignant. Percentage of euthyroid state after antithyroid drug?
Euthyroid state after antithyroid drug.
50%.
I think
In graves or in toxic multinodular goiter?
What?
In graves or in toxic multinodular goiter?
Toxic anti-steroid drug has no definitive therapy for toxic. It is, I think, question about Graves.
Graves, yes, 50%.
50% recurrence, so 50% cure.
Yes, of course, it is 50%. Dose of radioactivity in toxic multinodular goiter.
500 to
600 to 8.
500 to 800, I think.
800, yes.
Yeah.
Yes, of course. In Graves' disease, it is 400 to 600. Toxic multinodular 5 to 800. Toxic adenoma 500. Here Graves 5 to 8. Duration of avoidance of conception after radioactive iodine in male.
4 months.
4 months. 3 months.
4.
4.
2 months.
Another option.
4.
4 months.
4 months.
6 months according to the latest guidelines.
Oh, really?
Oh,
In the guidelines that
it was
published
6
in
for
the
the female
previous
and 4 for the male in
year,
Oxford.
this recommendation number 22 from the guidelines published previous year by European Thyroid Association guidelines for management of Graves' hyperthyroidism mentioned that conception should be postponed until at least 6 months after radioactive iodine in both male and female.
But at what year? At
I
which year
think-
this one, Dr. Khalid?
This is from the guidelines of published in previous year ETA guidelines, European Thyroid Association.
So
I know
it's
that
for Oxford or
all
The
our
recommendation is
I think it is different from the American Thyroid Association. They mentioned 3 to 6 months.
No. Yes.
But in Oxford, it's written clearly 4 months.
Yes. For
This is an
males,
update.
4 months, and females 6 months.
So
But I
we
think
should
if
know this recommendation
this
maybe
question-
change, something like that.
No. This is the latest recommendation published in 2018 in the previous year. These
So-
are guidelines. I think if the question in European board examination, I will answer 6 months for male, but in nice maybe 4 months. I don't know. In previous year, I answered 4 months, but in the next exam, I will answer 6 months in European board examination if it presents this question as the guidelines said. Another question, factitious thyrotoxicosis diagnosis, scan versus thyroglobulin.
Yes, thyroglobulin is low, so it's the one.
I think I don't know the best of 5 answers mentioned in the exam, but I think the
The
one
only
who put
one to decrease thyroglobulin, Dr. Khalid. So I think thyroglobulin.
yes, thyroglobulin or scan, I think thyroglobulin, but if
Because scan many can decrease it.
yes, this
The
Trap.
reduction.
Trap.
TRAB, of course, but the one who put the question mentioned that they did not mention TSH.
Fetal tachycardia. If heart rate is more than 150.
A fetal ultrasound?
170 for more than 10 minutes.
Yes.
Fetal
One?
BPM.
This is diagnosis of neonatal thyrotoxicosis. Diagnosis of
170?
This is for diagnosis of neonatal thyrotoxicosis. Fetal heart rate more than 170 for more than 10 minutes, and goitre and oligohydramnios, and a lot of criteria. Another one, treatment of anaplastic thyroid cancer with lymph node, anaplastic thyroid cancer. It is bloc thyroidectomy or external beam radiotherapy.
I think
Radiotherapy.
What?
Radiotherapy.
Radiotherapy. What is the best option for treatment of anaplastic thyroid cancer?
Because surgery, I think it will not help.
Why? It is anaplastic thyroid cancer. What is the treatment modality? Is it surgery or radiotherapy? The first choice.
Always it affect it's very malignant and affect all tissues. So
Yes, of course.
metastatic.
What is the first choice? Mainly surgery. If the patient cannot tolerate surgery or surgery is difficult or inoperable, so the external beam radiotherapy is the second option.
I agree with you,
The
Dr.
answer
Khaled.
here is the thyroidectomy.
I think it is in block thyroidectomy versus external beam radiotherapy.
I remember one question like that in my exam. It was about thyroid lymphoma.
Lymphoma, it is not surgery. Lymphoma, not surgery. Lymphoma
Because
radiotherapy or chemotherapy.
Or chemotherapy.
and in
Dr.
Oxford,
Khaled,
Yes, but
Dr. Khaled,
surgery
I
has
think
no
the
role in.
answer is radiotherapy, not a surgery, because anaplastic thyroid cancer, when you operate, it became more aggressive.
Yes, 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 of course. Yes, of course. I will mention it from medullary thyroid carcinoma, just anaplastic. This just one this book this from Oxford. Optimal result occur following total thyroidectomy. This is for anaplastic. This is usually not possible and external radiation is used. So طبعا we does not didn't know the exact case what is it, so we select according to the case. But if total thyroidectomy is available, so it is the first option for us. If not available or not possible, so the external radiation is the best option. This is a very important trick on amiodarone-induced thyrotoxicosis. Amiodarone-induced thyrotoxicosis given carbimazole and steroid, and after 4 to 6 weeks, his TSH decline. Which one to stop, carbimazole or steroid?
Carbimazole.
Yes, of course. Type 2 amiodarone-induced thyrotoxicosis, rapid response to treatment. So if we give carbimazole and steroid and the patient is normalized rapidly, so it is type 2, and we must stop carbimazole. If not rapidly controlled, so we must stop steroid and continue carbimazole. Okay, Dr. Khaldoun.
Okay, sir.
A pregnant woman with previous abortion and her TSH is 5. Treat or not to treat?
Treat.
Treat by levothyroxine, of course.
You know, Dr. Khaled,
What,
in this March in New England Journal, they saying it's not helpful.
Yes. Since a few days, published since a few days in
not helpful at all.
Yes, of course. There's a big paper in the New England Journal of Medicine published since a few days. Exactly.
It is not in the guidelines till now.
But I think the paper published in the New England Journal of New England Journal of Medicine published that levothyroxine is not effective in anti-TPO positive pregnant female subclinical hypothyroidism with anti-TPO positive. Yes.
Again, Dr. Khaled?
Since a few days published in the New England Journal of Medicine study, main conclusion about the management of subclinical hypothyroidism during pregnancy with positive anti-TPO found that treatment of levothyroxine has no rule.
I think, Dr. Khaled, I think the study which was published talking about normal thyroid function with positive antibodies.
Normal.
Yes.
normal. Of course, normal. It is normal. صح normal, Dr. Khaldoun, normal.
مظبوط. هنا TSH 5 we should treat.
I say normal. The study normal thyroid function with a positive anti-TPO.
But Dr. Khaled, it was before to keep TSH in the lower about 2.5. I think in the latest guidelines it was 4 or 5, something like that.
Yes, 4.
Yes, it is 4, not 2.5 anymore.
The latest guidelines, they publish that population-based trimester-specific reference range must be applied for reference range for TSH. If it is not applicable for us, the upper normal must be lower than by 0.05, and lower limit must be lowered by 0.04. So the upper normal accepted up to 4.
In which guidelines is Dr. Khalid? European?
American Thyroid Guideline, American Thyroid Association
Not
guidelines.
European.
American Thyroid Association. European is
So
still.
we will follow Society for Endocrinology or what?
What? American Thyroid Association. American Thyroid Association.
Okay, but in exam, I think in Society for Endocrinology guidelines it's 2.5.
Yes,
so
of
which
course.
one will follow?
It is 2.5. 2.5. European guidelines. Of course, it is European or nice guidelines. European guidelines is the first guidelines we will apply during the exam. It treated hyperthyroidism prevalent in the second trimester. Of course, it is carbimazole. This is most important one. TSHoma versus thyroid hormone resistance syndrome. How to differentiate? How to differentiate? In the exam, TRH stimulation test or TSH response to T3 or alpha subunit or MRI.
MRI is out, I think. MRI is out.
Can differentiate between TSHoma versus
I will do alpha subunit.
Another option?
The most useful it is TRH stimulation.
TRH stimulation.
You can use alpha subunit also.
Yes. As all we know, the alpha subunit is increased in TSHoma. TSH after TRH test is negative in TSHoma and positive in RTH. It is increased TSH. الالفا subunit is increased في TSHoma and negative في RTH. الMRI pituitary is positive في TSHoma. T3 suppression test no response في TSHoma and decreased في RTH. And genetic analysis is positive في RTH. This is the most methods to differentiate, but what is the best one of them? This paper published in European Journal of Endocrinology in the previous, I think, 1 or 2 years previously, and they present the steps to clarify flowchart to diagnose of TSHoma. The first step, pituitary function test, thyroid hormone evaluation for thyroid hormone, 6 hormone binding globulin, which increases TSHoma. The second step, they mention it is TRH test with TSH. The third step, TRH test with alpha subunit. Or the non-stimulated alpha subunit. And the latest one, T3 suppression test in parallel to MRI pituitary. MRI pituitary.
So to conclude, first one is TRH.
No. Still, في another guidelines published by European Thyroid Association about the TSHoma. I will mention after this. This one. European Thyroid Association guidelines for diagnosis of TSHoma. They do TSH and defect for measurement in relatives. The first step is to do pituitary MRI or CT scan. If it is normal,
Khalid, incident loma is very common. How can I do that?
I don't know. It is a flow chart from guidelines. They mentioned that by these steps, do TSH and 54, do pituitary MRI.